Ladies and gentlemen, I'm Clement Tham from the Chinese University of Hong Kong, and it is my great pleasure to speak on surgical treatment of angle closure. These are my financial disclosures. Now, given the limited time, rather than speaking on the whole range of laser and surgical options for angle closure, I'll try to focus on 4 most frequently asked questions in the management of angle closure. And here is my list. Now, the first question is, do we still perform laser peripheral iridotomy in PACS after the STEP trial? The STEP trial is short for Zhongshan Angle Closure Prevention Trial. And put simply, this trial randomized patients with bilateral PACS into receiving laser peripheral iridotomy in one eye and observation only for the fellow eye. And the primary endpoint was development of PAC by 72 months. Now, in this trial, it demonstrated that laser peripheral iridotomy in PACS, it reduced the risk of developing PAC or APAC by 47%. But even in those untreated cases of PACS, only 1 in 20 progressed to develop PAC over a period of 6 years. So this trial concluded that the incidence of angle closure disease in PACS by 6 years is very low, and laser peripheral iridotomy only offered modest effect in preventing angle closure disease. And possibly for this reason, this STEP trial has often been misquoted as saying that laser peripheral iridotomy should not be done in all cases of PACS. This is not entirely correct. In fact, the STEP trial concluded that widespread prophylactic LPI is not recommended on a population basis. In other words, it should not be performed in every single case as a routine, in every single case of PACS, but rather prophylactic laser peripheral iridotomy should be considered and reserved for those cases at highest risk of developing PACG. So what are the cases, what are the PACS cases at highest risk of developing PACG? Now, here is my proposed list. I would include the narrow-angled eyes in fellow eye of APAC patients. I would include those eyes with significant IOP increase after pupil dilatation. I would include eyes with very shallow anterior chambers, and also patients with a strong family history of primary angle closure glaucoma. Perhaps we should also consider eyes with high or even extreme hypermetropia. We should consider eyes requiring frequent pupil dilatation, for example, in diabetic patients, and also consider those patients with poor compliance with follow-up or poor access to ophthalmic care. Now, my second question is, when do we combine another IOP lowering intervention with phaco emulsification in PACD? Now, we know that lens extraction alone may not be sufficient in primary angle closure disease if there is very advanced glaucomatous optic neuropathy necessitating a very low target intraocular pressure, and also when there is a grossly uncontrolled intraocular pressure before surgery. Now, I think in our surgical decision-making, first of all, we have to consider how much intraocular pressure and or drug reduction is required for a particular eye. And to address this question, we would have to take into consideration the preoperative IOP and drug requirement, the stage of the glaucoma disease and the target intraocular pressure, and as well as the patient's age and the rate of progression of the disease. The second question we have to consider is how much surgical risk the patient or the surgeon can accept. And to address this, we will have to take into consideration the status of the operated eye, as well as the fellow eye, and also the patient's visual requirement, including the patient's work, as well as hobbies. Of course, the final decision would have to be made after a very thorough discussion of the pros, cons, and risks of each surgical option with the patient. Now, I've borrowed this slide from my other talk, and all I want to do is to show you a small list of other IOP lowering surgery that can be combined with phacoemulsification in PACD. And these include goniosiniculitis, various forms of cyclophotocoagulation, some forms of mixed trabeculectomy, as well as perhaps glaucoma drainage device implantation. Now, here is my own personal lens extraction treatment spectrum. For those cases that do not require substantial IOP reduction, I will perform phacoemulsification alone. If I need more IOP reduction, I would consider combined phaco and endoscopic cyclophotocoagulation. And for those cases requiring substantial IOP reduction, I would perform combined phacotrabeculectomy. Now, my third question is there still a role for goniosiniculitis? Now, in many studies on the clinical outcomes of goniosiniculitis, the authors have combined GSL with phacoemulsification. And so in those studies, it is often very difficult to identify the exact contribution from GSL in lowering intraocular pressure. But here is one study that looks at only performing goniosiniculitis in advanced cases of CACG, and they demonstrated that the mean intraocular pressure reduction can be over 63%. Now here is a randomized controlled trial from the Singapore group, which randomized PAC and PACG patients into receiving either phacoemulsification or combined phaco-GSL. And they demonstrated no additional statistically significant IOP lowering benefits of phaco-GSL over phacoemulsification alone. And this study is often quoted as the strong evidence that GSL may be of limited or even no use in PACD. But I would like to point out two important limitations of this study. First of all, the mean preoperative intraocular pressure was only around 22 millimeters mercury in both study groups, which is not very high. And secondly, the inclusion criteria was of 90 degree of PAS or more, which is also very not extensive extent of PAS. Now, there are certain possible reasons why GSL may not be effective in some PACD cases. First of all, the underlying trabecular mesh network could have been irreversibly damaged. A previous study has demonstrated that GSL may have better clinical outcomes in those cases with earlier stage of primary angle closure, and also in those cases with more acute presentation of primary angle closure. And for this particular reason, an ongoing clinical trial is now looking at the effect of combining goniosiniculitis with goniotomy, with the latter procedure, goniotomy, dealing with the irreversible damage at the trabecular meshwork level. So eventually, the outcome of this clinical trial would be extremely interesting. Furthermore, after GSL, there can be reclosure of the drainage angle, and to address this, we may consider adjunctive argon laser peripheral iridoplasty after goniosiniculitis. So my simple answer to the question whether there is still a role for GSL is yes, but patient selection is likely critically important. But then, of course, as always, more studies are needed. Now, finally, what is the best treatment option for acute primary angle closure? To cut a long story short, I'll just share with you our approach in Hong Kong. For all cases of acute primary angle closure, we perform immediate laser peripheral iridoplasty with either argon or diode laser. And once the pressure is initially controlled, the inflammation has largely settled, we perform early lens extraction. And here are my typical laser parameters for ALPI in these eyes. I use a relatively larger spot size of 500 microns, a relatively longer duration of 0.5 seconds. And for brown iris, I start from a low laser power of 150 milliwatts. For lighter iris, you may consider using a higher laser power. So thank you very much for your kind attention. If you are interested to learn more about glaucoma or other subspecialty areas in ophthalmology, Please do come and join us in Kuala Lumpur, Malaysia in February 2023 for the 38th Asia Pacific Academy of Ophthalmology Congress. I'm very much looking forward to seeing you then. Thank you very much once again.